Actually, during the synthesis of hemoglobin, the first molecule which is made, this molecule is called pyrrole ring. So erythroblast first of all produce pyrrole rings. Then 4 pyrrole rings are put together, assembled. These are 4 pyrrole rings. If they are put together, this structure is called protoporphyrin. Then, if this is protoporphyrin, in the center of protoporphyrin, if you put iron, what you put? Iron. Then it is called heme. Is that right? Again, erythroblast make initially pyrrole rings, assemble them into protoporphyrin rings, and protoporphyrin ring, in the center of that they put iron, and then there is heme. And then they synthesize the globin chain, and with the heme they put one, this is heme, protoporphyrin ring with iron, and they put a globin chain, right? And now what is this called? Hemoglobin monomer. What is this called? Hemoglobin monomer. But basically hemoglobin is a tetrameric protein, right? So there are tetramers. Now listen. Actually, there are different type of globin chains which can be synthesized. This was suppose alpha globin chain. Erythroblast can also produce beta globin chain, which is called beta chains, and it can also produce, yes, gamma globin chain, and it can also produce, yes, another type of, all of them of chains are with the heme, and this chain is delta chain. So globin chains can be alpha chains, beta chain, gamma chain, and delta chain. Is that right? Now, these are different type of monomers of hemoglobin. Now, if there are 2 monomers with alpha chain plus 2 monomers with beta chains, then this hemoglobin is called hemoglobin A. A for adult, because in adult most of the hemoglobin has 2 alpha chains and 2 beta chains. Then in adult another variety is found. 96% of the hemoglobin is of this configuration. About 2 to 3% hemoglobin is 2 alpha chains with plus 2 delta chains. That is called hemoglobin A2. That is called hemoglobin A2. Then in fetus, usually 2 alpha chains are combined with 2 gamma chains, and that is called fetal hemoglobin, hemoglobin F. Is that right? So what we really understand that alpha chains are present in all hemoglobin, adult hemoglobin or A2 hemoglobin or F hemoglobin. But actually, if 2 alpha are with 2 beta, this will become adult hemoglobin A. If 2 alpha are with 2 delta, then these are hemoglobin. And if they are 2 alpha with 2 gamma, then it is hemoglobin F. Now let's have a test. If 2 alpha with 2 delta, what will they make? Hemoglobin A2. If 2 alpha with 2 beta, hemoglobin A. If 2 alpha with 2 gamma, hemoglobin F. Another important thing. Actually, fetal hemoglobin with gamma chains, it has more strongly, it has more strong affinity for oxygen, so that it can really pull the oxygen from maternal circulation to fetal circulation. So fetus is very clever. It does not activate beta chain or delta chain genes, it activates gamma chain genes. So in the fetus, hemoglobin is 2 alpha 2 gamma. Actually, why this hemoglobin has an advantage for the fetus? Because this hemoglobin has stronger affinity for what? Oxygen. So it can pull the oxygen from the circulation of the mother to the fetal circulation. Is that right? Okay. Another thing which I would like to mention here, that if there is some mutation in the genes which produce these chains, right, then there can be problems. For example, if a person has mutation in mutant beta chains, so he is not making the beta chains at all. Let's suppose these are the genes. This is alpha gene, this is for beta gene and beta gene, this is gamma gene and gamma gene. I'm just giving you an example. Let's suppose if beta genes are defective, then what will happen? This person initially in fetal life will make alpha with gamma. So that is which gene? Which hemoglobin? F. But actually, this baby after the birth, he should make alpha with beta. But if beta are defective, he will keep on producing alpha with gamma. Is that right? This type of diseases in which there is quantitative deficiency of any type, some type of globin chain. This type of diseases are called thalassemias. Have you heard of thalassemias? Thalassemias are diseases in which there is quantitative problems with the production of globin chains, right? And certain globin chains are not produced with proper ratio, right? Thalassemias. Right. Then we come to another concept. Do you know something about blood groupings, ABO and RH blood grouping? You want to know something or you know it well? You want to know it?
Yes.
Okay, I will talk very briefly about that. That there are so many ways to group the blood group, right? Typing of the blood grouping can be done, but two important grouping I will talk about is ABO blood grouping and RH blood grouping, right? First, let me tell you what is meant by the ABO blood grouping. Actually, on RBC surface, right, different people express different antigens, right? Some people express, okay, I will make a full chart here. Some people on the RBC surface, they only express A antigen, and some people express only B antigens. Let's suppose these are 4 different persons. Person number 1, person number 2, person number 3, person number 4. Now, person number 1 on his RBCs, he is expressing only A antigen. Is that right? A antigens. The persons who express A antigens on their RBCs, they are called blood group A. It's so easy. And people who express B antigens on their RBC surface, they are called blood group B. Some people are expressing the both antigens, right? So they are called blood group AB, right? AB. And some of them don't express, they simply express an H antigen. Actually, H can be modified into A and B. H antigen is expressed by all of them. H can be modified into A or can be modified into B. And some people H is there and it is not modified into A and B. And H is not immunogenic, it does not stimulate the immune system. So practically we can say these people do not have A and they do not have B. Are you really clear what I'm talking about? No?
Yeah.
Right. So H antigen is present, H molecule is present on all of them. It can be modified into A or can be modified into B. And in some people, the enzymes which have a capability to modify into A and B, they are not there. So practically they don't have A, they don't have B antigen. So we call them blood group O. So in a way, this is blood group A, right? This is blood group B, this is blood group AB, and this patient has O. O is no A, no B. Is that right? Now there is another thing. Actually, A and B antigens are present in environment also. And these antigens are also present in microbes. So when we eat, many of these A and B antigens come to our GIT. And these antigens which are coming through foreign sources, they try to stimulate our immune system. They try to stimulate our immune system. Now listen. For example, person number 1 is blood group A. Now in blood group A person, A and B antigen will be coming to his immune system stimulation from the microbe and from the diet. But when A antigen will come, A antigen will be perceived as self antigen because this antigen is coming from environment, but it is also present in his own body. So A antigen, because it is his own antigen, do you think his person's immune system will make anti-A antibody? No. So in this person, the person who has A antigen, he does not make anti-A antibodies. But when B antigen come to his system, right, and B antigen is not present in his own system, so his immune system is going to perceive B as foreign antigen, so he will make anti-B. So what really happens that antibodies present in blood group A patient are anti-B. And people who are blood group B, right, when their immune system is challenged by A and B foreign antigens, they will not make anti-B because B is their self, but they will make anti-A. They will make anti-A antibodies. These antibodies are called also heme agglutinins, right? Anyway, person who has A and B both antigens as self antigens, when foreign A and B antigens come through microbe and diet, do you think their immune system will make anti-A and anti-B antigens? No. So they don't have antibodies. But person who has no A antigen, no B antigen, whereas in this person's body, through the diet or through the microbe, A and B antigens come, he is going to make anti-A antibodies as well as he is going to make anti-B antibodies. So is it clear? That again, person who has blood group A, he is having A antigen on the RBCs and in his plasma he has anti-B antibodies. Person who has blood group B, he has which antigen on RBCs? No. Which antigen on RBCs? B. And which antibody in the blood? Anti-A antibody. Right? Person who has a blood group A and B, he is having which antigens expressed on RBCs? A and B both antigens. And in his plasma which antibodies are there? No, there are no anti-A, no anti-B. Other antibodies against other antigen may be there in the body. You make him totally immuno-incompetent. Okay. Person who has blood group O. Yeah. Person who has blood group O, he does not have A antigen, he does not have B antigen. So he will develop anti-A and anti-B. Is that clear? Now, we talk about ABO incompatibility. You heard of this, isn't it? Now we talk about ABO incompatibility. First, listen a basic rule. Let's suppose you are going to do a blood transfusion. This is the circulatory system of recipient person, right? If you bring the donor's RBC, these are the donor RBC which are going in his body. And this is the donor plasma which is also going to his body. Is that right? Now listen carefully. In donor RBC, let's suppose this is donor RBC is A. It means donor blood group is A. And by mistake, if you give A blood to a person who is B group, it means this person has which antigen on his RBCs? B. Recipient has a blood group B, and unfortunately you have given the recipient a blood which is blood group A. So recipient RBCs have B antigen and anti-A antibodies, anti-A antibodies, which are already present in the serum of or plasma of recipient. And when you bring the donor RBCs, which are having concentrated A antigens on the RBC membrane, anti-A will attack the donor RBCs and destroy the donor RBCs. So what really happens in ABO incompatibility, these are the donor RBCs which have a risk of being destroyed in recipient circulation. I'm the recipient. Okay, let's suppose this is the donor. Please come here. Let's have a look on the donor. Right? Come on this side. Let's suppose this person has blood group A and I'm having a blood group B. His RBCs are having which antigen? A antigen. My RBCs are having B antigen. His plasma has which antibody? Anti-B. And my plasma has anti-A. Clear? Now, if by mistake you put his blood in my circulation, when his RBCs will come to my circulation, his RBC membrane has thousands and thousands and thousands of A antigens concentrated. And my plasma has anti-A. So my anti-A will attack the donated RBCs and destroy them. And hemoglobin will be released in my circulation from the ruptured donor's RBCs. Hemoglobin is released and this free hemoglobin will damage my kidney, right, produce kidney failure, activate a lot of mast cells which will release a lot of histamine and my blood vessels will dilate, I may go into shock. That is a dangerous situation, right? So donors RBCs in case of ABO incompatibility will be destroyed in recipient circulation and produce problems. But another important point. But donor's antibodies, he was having anti-B antibodies. His antibodies will also come to me, but they will get rapidly diluted in my circulation. Right? So donor's antibodies usually do not attack recipient RBC, but recipient's antibodies do attack the donor's RBCs if there is AB incompatibility. Am I clear to everyone?
Why don't his antibodies attack your antibodies?
Look, his antibodies are in plasma. He is having anti-B antibodies. Now, his plasma fluid is diluted into all my plasma, right? And antibodies become so subcritical concentration that they don't effectively destroy my RBCs. Is that right? But when his RBC comes, his RBCs are having thousands and thousands of antigens concentrated on his RBC membrane. Can those antigens get diluted in my body? No, they remain concentrated on donor's RBC surface. So they are very effectively attacked by my antibodies. So what really happens in AB incompatibilities, these are the donor RBCs which are attacked by the recipient antibodies, and donor's RBCs rupture in recipient's circulation and produce problems. But donor's antibodies get diluted in the huge volume of plasma of the recipient person. Am I clear to everyone? Please have a seat. You are about to kill me.
Good job, Han. So it's the hemoglobin from the donor's RBCs that causes all the problems?
Hemoglobin, which is actually when donor's RBCs rupture in recipient circulation, then free hemoglobin produces the problem. Is that right? For example, free hemoglobin can leak through glomerular membranes and damage our kidneys, especially proximal convoluted tubules. Anyway, let's come back. So now we talk about it. That person who has blood group A, can you give him A blood group? Yes. Can you give him B blood group? No, because he has anti-A. B blood group we cannot give, because when B RBCs will enter into A circulation, A person has anti-B antibodies, so donated RBCs will be ruptured. Can he be given AB blood group? No, because again donor's RBCs will be destroyed by anti-B. Can he be given O?
Yes.
Yes, because O does not have A or B. So anti-B cannot destroy the O-coated RBCs. Clear? Now we come to person who has a blood group B. He has which antibody? Anti-A. Can he get blood group A? No. Can he get blood group B? Yes. Can he get AB? No, because anti-A will destroy the A RBCs, A antigen. And can he get O? Yes. Now we come to the person with blood group AB. So this person does not have any antibody, no anti-A, no anti-B. Can he receive blood group A?
Yes.
Can he receive blood group B?
Yes.
Can he receive AB?
Yes.
And can he receive O? Yes. Why? Again, person who has blood group AB, he does not have anti-A antibodies, he does not have in circulation anti-B antibodies. So he receives A RBCs with A antigen or B antigen with AB antigen or O antigen. None of these RBCs are destroyed because he is not having anti-A or anti-B antibodies. But the person who has blood group O, he is having anti-A and anti-B antibodies. So can he receive, should he receive the blood group A? No. Should he receive B? No. Should he receive AB? No. Should he receive O? Yes. Now if you really look at it, what we see that every group can receive the O. Is that right? Because O RBCs of O blood group do not have A and B antigen. So whatever person's circulation they go, they will not be destroyed by anti-A or anti-B. So blood group O people are said to be universal donors. They are said to be universal donor. Opposite to that, when we talk about AB blood group, right, they can receive blood from everyone, because people who have AB blood group, they do not have anti-A antibodies, they do not have anti-B antibodies, because they do not have anti-A antibodies and anti-B antibodies. So you put A, B or AB or O RBCs, they will not be destroyed. So they are universal recipient. So ABO blood group is universal recipient and O blood group is universal donor. Is that right? I hope this concept is clear. Right. Now we talk about RH blood group. Only few words. Or you want to have a break?
No, I just want to know what kind of blood type you use.
Now, RH antigen is present in some people's RBCs and it is not present in some other people's RBCs. RH antigen was first of all discovered in some monkeys, rhesus monkeys RBCs. So that is called rhesus antigen or RH antigen. Now, the RBCs which are having RH antigen, right? RBCs which have RH antigen, they are said to be RH positive. And RBCs which do not have RH antigen, they are said to be RH negative. And if I say my blood group is A positive, it means I have A antigen plus RH antigen. If I say your blood group is A negative, it means you have A antigen but no RH. If I say you are AB positive, it means you have A antigen on RBCs, B antigen on RBCs as well as RH. If I say you are O negative, it means you do not have A antigen, you do not have B antigen, you do not have RH. You understand this concept? Now, the special precaution which we have to make about RH system is, we'll talk about that precaution later. First, as I told you, A and B antigens are present in nature. So they come to us from microbes and from the diet. RH antigen is not present in nature abundantly, not present in microbes, and RH antigen is not present in diet. So it is not normally coming to us. Is that right? Now, if I am RH positive person, my RBCs are RH positive person, right? Because from the nature, no RH antigens come, I will not make anti-RH. But even if you put some other person's RBCs which are RH positive to my circulation, still I will not make anti-RH because RH antigen is considered my self antigen. Am I clear? Now, but if there is a person who is RH negative, if there is a person who is RH negative, in that person normally anti-RH antibodies are not present. Are you understanding? Person who are RH negative, they don't make anti-RH antibodies spontaneously. But a person who is RH negative, if that person get RH positive RBCs in her body, then that person can make anti-RH antibodies. Am I clear? Now I will give you a classical example which is also clinically related. Let's suppose there is a woman who is RH negative. You know, some women are RH positive and some women are RH negative. Let's suppose there is a woman who is RH negative and she gets pregnant and unfortunately she is carrying a baby which is RH positive. Of course, that RH positive gene came from paternal side, right? Let's suppose, look at her situation. This is maternal circulation, mother circulation. Her RBCs are RH negative. She does not have RH antigen. And here is the happy baby, right? And this baby has an RBC which is RH positive. She is first time pregnant, and this is RH negative mother which is carrying RH positive baby. Now what really happens that during the pregnancy, but mostly just after the delivery, a little blood from the baby goes to the mother, about half ml blood, right? So what really happens when this is the first baby. When first baby is delivered, when this woman which is RH negative, she was carrying RH positive baby, fetus, and when she delivers first baby, at the time of delivery, when placenta detaches from the uterus, a small amount of fetal blood goes to the mother. And then mother, this baby is out of course. Right? This first baby is out, but during its delivery, some of its blood went to mother, which was RBCs which are RH positive. No, fetal RBCs were RH positive. This baby has gone out, no trouble to it. But when mother immune system will receive RH positive RBCs, do you think RH antigen is natural for mother? No. So mother will make anti-RH antibodies. Now this lady who is herself Rh negative, but she is carrying which antibodies in her blood? Anti-Rh antibodies. She will not have any problem herself because her RBCs are Rh negative, and anti-Rh antibodies she has made due to stimulation coming from the first baby. These antibodies will not disturb her. Let's suppose after 2 years she again becomes pregnant. Now she is having the second baby, right? And this baby is also Rh positive. This baby is also Rh positive, right? But now mother circulation is different. You know, the naughty first baby, he stimulated mother immune system on the way when he was out, and mother made anti-Rh antibodies. So mother was having anti-Rh antibodies due to her prior exposure to Rh antigen. So when she will be pregnant and carrying the second fetus, anti-Rh antibody belong to IgG group and it can cross placenta. So it will come to this baby, and this anti-Rh antibodies from maternal plasma come to the fetus and bind with the fetal RBCs and destroy them. So when this baby will be born, this baby will have anemia, severe anemia, because hemolysis is going on, because maternal anti-Rh antibodies are destroying baby's RBCs. But this second baby also gives some, at time of delivery, gives some Rh positive RBCs, and mother immune system now make more anti-Rh, and trouble is more for the third baby. You know, life is strange. This time she is carrying the third baby. I think this must be right. Why? Because first baby stimulated the mother by giving a little blood, and mother made anti-Rh antibody. Second baby also gave Rh positive RBCs to the mother. Mother made a lot of anti-Rh antibodies, and lot of anti-Rh antibodies come, and now baby's RBCs are destroyed in very seriously. And when the severe destruction of RBCs, then to compensate for these RBCs loss, baby has excessive hematopoiesis. And due to excessive hematopoiesis, baby's liver and spleen enlarge, because you know in the fetus liver and spleen act as hematopoietic organs, but by the time of birth most of the hematopoiesis is from the bone marrow. But because in this baby a lot of destruction of RBCs are going on, so liver and spleen continue their hematopoiesis and they become enlarged due to increased hematopoiesis, and bone marrow also does. So this baby is born with hepatomegaly and splenomegaly and still a lot of what? Severe anemia. And lot of these RBCs which are destroyed, they are releasing bilirubin, unconjugated bilirubin, which may go to the brain of this baby, because babies are having, newborn are having immature blood-brain barrier. So when these RBCs are rapidly destroyed, they release the they release lot of hemoglobin, which is eventually releasing bilirubin. Breakdown product of RBCs is bilirubin, and this heavy amount of bilirubin may cross the blood-brain barrier, and this may go to the baby's central nervous system, destroys cortex and basal ganglia. So this baby will develop really weeping much. This baby will develop mental retardation and motor disorders and problems like this, right? Woman is determined to have more babies.
Don't they give them medicine after the first pregnancy?
Yeah, they will. There will be some good doctors like Dr. Gigi will be there, and she will do some treatment. Yes, we'll talk about this for sure. Now, unfortunately, she was in the third world, not taken care properly, and she is very keen to have more children. Now this time what will happen? The real sad thing. Again the baby is Rh positive. And what will be the problem with this baby? The mother has so much Rh anti-Rh antibodies that very severe destruction of baby's RBCs. And baby has a very large liver, very large spleen, and still very heavy hematopoiesis cannot match the losses of RBCs. So blood becomes very thick or thin? Thin, because most of the RBCs are destroyed, and heart of the baby fails to maintain the circulation. Is that right? So baby also develop cardiac failure, and in advanced classes you will know when someone develop cardiac failure, there is generalized edema. So this baby has hepatomegaly, splenomegaly, and due to heart failure, baby develop generalized edema. And this baby will be very much edematous baby. So we call it hydrops fetalis, fetus full of water, hydrops fetalis. And mother cannot maybe deliver it through normal birth canal. During this process, either mother will die or some doctor in the third world, he will cut the baby into pieces and bring it out to save the mother life. Or you will do C-section if the facilities are available and bring the baby out, but it's full of water. Is that right? And usually many of these babies die within the uterus, right? Mother is already having one child which is mentally retarded, and now she has this tragedy, right? Another problem during this situation occur that because in these babies hematopoiesis continues in liver and spleen, right? Now, hematopoietic function in liver and spleen is different than hematopoiesis in bone marrow. Bone marrow is such a clever organ that it only allows mature product to go into circulation. You are understanding? From bone marrow, when bone marrow is doing hematopoiesis, do you think pro-erythroblasts come into circulation? No, only reticulocyte and RBCs come into circulation, right? So actually, your bone marrow stroma is so much, you can say, so well functional that it only allows the mature RBCs, WBCs and platelets to go into circulation. But liver and spleen are not so good hematopoietic organs, and if they continue their hematopoiesis for a long time, they allow the precursor cells also to jump into circulation. So in these babies who are born with continued hematopoiesis in liver and spleen, they have a lot of erythroblasts into their circulation of these babies. When these babies were born, right, doctors took their cord blood and tried to see what is wrong, and they found that these fetuses which were having severe jaundice or having hepatosplenomegaly, or in severe cases having, what is that? Generalized edema, they found in the blood of these babies or newborn fetus there are a lot of erythroblast. Because what is the underlying cause for that erythroblastosis present in the blood? Because hematopoiesis are going in liver and spleen, and they allow the immature precursors also to come into blood. So doctors at that time, when they never understood the mechanism of this disease, they just said this is a disease of a fetus in which a lot of erythroblasts are found in the blood. So they called this disease erythroblastosis fetalis. What was this disease called? Condition of the baby? Erythroblastosis fetalis. Am I clear? So that is why now, yes, we come to Dr. Gigi. The Dr. Gigi was asking, is there any treatment? She is very much concerned. So we should be concerned about patients. There is treatment now available. What we do, that now commercially available anti-RH antibodies are there. There are injections available, injectable forms of anti-RH antibodies. The injection comes with the name of RhoGAM. Right? Now, RH immunoglobulins, RhoGAM. RhoGAM, the injections are available. What doctors do, it's international standard of pediatric, you can say, obstetric care, that any woman who is RH negative, right, as soon as she gives birth to a baby, immediately baby's blood should be checked. If baby is RH positive, immediately mother should be injected, within 72 hours, mother should be injected with injection of RhoGAM. What is the advantage of injecting the mother with RhoGAM? Let's suppose this was her first baby born. We already knew mother was A negative and baby is supposed AB positive. So it means RH negative mother has given birth to RH positive baby. So probably some baby's RBCs are present in maternal circulation, and these RBCs are RH positive. We inject the mother with anti-RH antibodies. These antibodies will come, and these antibodies will bind with the circulating fetal RBCs and destroy them. When these fetal RBCs are rapidly destroyed in mother circulation, so these RBCs are never detected by the immune system, so immune system never make anti-RH antibodies. In this way, mother becomes safe for the next baby. So this is international practice now, that whenever RH negative mother give birth to RH positive baby, mother within 72 hours of the delivery of the baby should be injected with RhoGAM. right? These are anti-Rh antibodies. We also call it anti-D antibodies. Rh antibodies, Rh gene or Rh antigen has 3 types, D, C and E, right? Anyway, these antibodies are also called ROGAM antibodies or anti-Rh antibodies or anti-D antibodies, so that any mother who is Rh negative herself give birth to Rh positive baby, that mother should be injected with anti-Rh antibodies so that in fetal RBCs in maternal circulation should be coated by those antibodies, and antibody-coated RBCs are rapidly eliminated by the macrophages of the mother in spleen. So maternal circulation becomes free of fetal RBCs, and because RBCs are rapidly destroyed, so if they are present, fetal RBCs are present for a very short time in maternal circulation, they don't produce enough stimulation to the mother immune system, so mother does not produce enough anti-Rh antibodies. Yes, what's your question?
Is IgG able to cross the placental barrier, or is it IgM?
Pardon?
Is it IgG able to cross the placental
IgG,
barrier? G.
IgG, yes, this is IgG antibody crosses the placental barrier. This has some benefit also, that IgG antibodies, for example, a woman who is from Africa, she has been exposed to African infections. So all her life he kept on making anti-IgG antibodies against many microbes. When she will have a baby, so all the IgG antibodies she has in her circulation, they will go to the baby, and baby will be protected against those infections. Is that right? So every woman who becomes pregnant, whatever pool of IgG antibodies she has, she gifted to the baby. Is that right? So that when baby is born to the new world, right, it should have some degree of protection, immunity. Am I clear? Any more question? Yes.
What if the
Now another thing, why IgM does not cross? Listen, when anyone get infection, initially you make IgM, but if infection come again and again, you make IgG. Now listen, for example, you have a Japanese woman here who is pregnant. In her blood, she will have IgM against only those infections which she has recent infection. But IgG antibodies are present in body for long time. So when Japanese woman is pregnant, in her blood she has IgG antibodies against the infection which she had 10 years back or 5 years back or 2 years back. So actually everyone has lot of IgG according to the exposure to the antigens in the past. So whenever you get a new antigen, you make IgM for recent use and IgG for long-term use. Again, this is very important. So whenever you get any infection, right, immune system make IgM for recent use and IgG for long-term use. So when any infection come again and again, the IgG keep on getting boosted. Is that right? So what really happens that if mother give, let's suppose theoretically, if mother give IgM to the baby, then baby will get IgM only against those antigens which mother received during her pregnancy. But if mother is giving IgG to the baby, it means mother is giving all those protective manners which she developed against all the antigens which she was exposed in her life. Is that clear? So what is more beneficial to the baby, to receive IgM or IgG?
IgG.
That is why placenta has receptors for IgG. So maternal circulation, IgG bind with the placenta, and then through pinocytosis process, IgG is taken from maternal circulation to the fetal circulation and gifted to the baby.
So IgM is not.
Yeah, IgM is not transported significantly from maternal circulation to the baby circulation. And once baby is born and mother nurses the baby, feeds the baby, then through the milk IgA goes to the baby. So newborn baby is receiving IgA through the breast milk and already have received IgG from maternal circulation. This IgG from maternal circulation stays in baby's blood for about 4 or 5 months. That is why many babies have a high risk of infections or after that time. Right? Any more question? Yes.
what if the mother is Rh positive and the baby's Rh negative?
Okay, she has come up with a question. If mother is Rh positive and baby is Rh negative, what will happen? Nothing will happen, but baby I hope should be born. If mother is Rh positive, will she make anti-Rh antibodies?
No.
No. And secondly, if baby has no Rh antigen, do you think baby has any type of risk from anywhere? No,
So nothing ever happens?
nothing will happen.
Oh, okay.
This is a special condition in which Rh negative mothers are giving birth to Rh positive baby. So the risk is that if it is first delivery, the mother immune system is stimulated to make anti-Rh, and if it is she has previous deliveries also, then maybe this baby is born. If mother had already developed anti-Rh antibodies, then this baby may be suffering. But if mother is Rh negative and baby is Rh negative, do you think there will be any problem? Not at all.
So they give one time and then they never give it again?
No, they just give, when Rh negative mother gives birth to Rh positive baby, they give injection once after the, what is this? Delivery of the baby. Then they don't give it. Yeah. Right? Any question? No? Class dismiss.